communicable disease, and equitable mobility solution in cities, to name a few. He has written, co-edited 4 monographs and published 37 research articles in several reputed international and national journals and 8 chapters in edited books. Professor Ajay Bailey is passionate about qualitative research, teaching and capacity building of the young researchers. His work significantly contributes to expanding the field of transnational mobilities, aging, intergenerational relations, health system research, health services, reducing barriers to care while establishing meaningful North-South and South-South collaboration. Of course, his CV is very long enough, but due to paucity of time, this is a very short CV that this is the introduction about Professor Ajay Bailey. Professor Ajay Bailey, please, you are most welcome to take over and deliver your lecture. Thank you very much.
Thank you, Professor Madheshwaran. First, I would like to thank Isaac and the chairman, Professor Madheshwaran, and Dr. Sobin for inviting me. Of course, I'm not new to Isaac. We've been working for the past more than almost 10 years actually now, since we started working with Professor James on the aging research. And we've had students who have graduated recently and who will soon graduate together with Isaac and University of Groningen and Utrecht University. I see someone scratching things onto the thing, so maybe, yeah. It would be great that I present some of this work that I'm doing also on risk communication, and this really is the interface between my work within anthropology and public health, and to look at how that plays a role in understanding risk behaviors. So I'll speak today on the social impact of risk communication on vulnerable groups, and I will use a framework to explain how we can understand the social impact. And I thank Professor Madheshwaran to highlight or flag up these questions, because these questions will come back in the slides that follow and this framework of how we understand risk communication, but in a more simpler manner, risk information actually, and how that impacts behaviors, both our own and those who surround us. So risk communication refers to the exchange of real-time information, including advice, opinions, experts. You know, you put on your TV, I think in India, you have so many channels that they keep reporting about COVID cases here, there, and reporting of different things. It is risk communication in that it comes in various forms. It could come through media, it could come through print channels, it could come through your neighbor, it could come through your employer, as Professor Madhesh was saying, how do you then deal with quarantining people on campus, for example. So risk communication is not just that arrives from the government, but also of what we as individuals, as researchers, as people within the community communicate about the information as well. And this has an impact on the health, on economic and social well-being. It's one of the key elements in prevention and control of diseases, because it can supply individuals with the knowledge needed for optimal decision making, both for protective and preventive behavior. You may wonder why do we need this information? This information gives us the know-how about what do we know in case of this illness. And risk communication is not just about health, it's about all kinds of things. It could be about earthquakes, then it comes in the realm of disaster management, for example. It could be in the realm of other kind of diseases. There's been much work done within HIV and AIDS, for example, that focused on risk behavior and risk communication. So many of the models, theories, and concepts that have been developed on behavior change, on understanding behaviors, come from this field of risk and risk behaviors. So risk communication should emerge long before a crisis occurs. So that talks about how prepared is the health system to deal with this crisis. it aims to reduce likelihood of a further bigger crisis event. Our main thing over here is to understand how the disease progresses. Of course, in the case of COVID, there um, there was no new information. There was no information available that they could start off. So a lot of the information you may have observed, not just in India but also here in the Netherlands and in other countries, was on the go kind of an approach, because the manner in which the spread was going ahead, the groups that it had an impact on kept on changing. So communication and information also has to change in a more dynamic manner as and when the outbreak changes. Also, the groups change. It can change from specific hotspots to community-led transmission. So all these things play a role in understanding the knowledge that is needed for individuals to take key decisions on how to protect themselves and their families. Effective risk communication rebuilds trusts among individuals and stakeholders, because if people do not trust this information, they are less likely to take an action, or less likely to take the recommended action in that sense. Risk communication suffers majorly when there are lack of clear guidelines on what needs to be done, or the guidelines keep changing constantly without having any justification of why they have changed certain guidelines. So this puts people at a loss in terms of, okay, a month before we were asked to do this, a month later we are asked to do something else. How do we make sense of this situation? So communication is not just about presenting facts, but also presenting justifications, reasons, explaining things to people. So not just having that tracker on your TV screen, which keeps saying the number of cases, number of tests, but also about preventive measures. We need to also contextualize information to different groups. Much of the information that has been circulated focuses on elites or urban groups, literate groups. What about low literate populations, for example? A whole lot of information that comes with particular groups or people who are exposed to a large amount of channels of information can also face undue sense of anxiety that it could happen here. And depending on your life course, your age, your control of the situation in which you live, this anxiety can create other kind of conditions. So most probably COVID may be one of this infection, but you may be suffering from higher levels of anxiety due to the conditions that surround COVID or COVID-like situations. Risk communication also has a major negative impact with regard to fake news. And there has been quite some information, especially WhatsApp groups, widespread discrimination based on certain groups. If you look at this whole element within COVID-19, there is no mosquito that you can blame. There is no organism that you can directly blame, that is visible, that you can blame for the spread of this disease. A lot of the spread is through contact, through people meeting each other. So what we see over here is a kind of othering of risk. Let's say, oh, it happens because of those kind of people. So it's not because of what I do, that I don't wear a mask or I go to crowded places. It's because of those people. So this kind of othering of risk, saying that it's out there, and I'm not to be blamed for it. It brings us to this kind of seminal work of Mary Douglas, who talks about risk and blame in terms of epidemics or pandemics. What comes to mind is in terms of HIV and AIDS as well, is this whole idea of risk and blame. Whom do we blame? Or who has to carry this blame for the risk that occurs within this community? So similarly, with regard to risk communication, the focus should not be on blaming particular groups, but the focus should be on how to empower these groups with more information, more not just facts, but also information on that can be easily understood and can be enacted given the situation that they live in. Yeah. With any new disease or condition, we see that there is a lot of uncertainty. And uncertainty is not just among the lay people, but also among healthcare providers or government organizations, because they have not dealt with this kind of a situation. They don't have a framework. There is no protocol on how do you deal with these kind of pandemics, because all of this information is evolving as the outbreak intensifies. In future outbreaks, I think countries will have a chance to be more prepared uh, with dealing with this uncertainty. When there is heightened level of uncertainty, this intensifies underlying inequalities. Especially what you see was this mass exodus of migrant labor from major cities, the discrimination that happens with particular groups, that they are closed down without any consideration for income. How are they going to livelihoods that are affected, and how that has a negative social impact. So when we talk about risk communication, it is more beyond just the facts, just the numbers, number of cases tested. It's also about how this information that flows down from at the different levels has an impact on at the individual level. I think it has the impact at that risk perception at the individual level. So to better understand this process, I will use or will discuss here. Oops. The social amplification of risk framework. This is a framework given by Kaspersson and colleagues. It was first introduced in 1988 and since then has evolved to understand how communication has moved across different sectors. And this has been applied across various domains, mostly within journalism, and how it has impacted groups, or how media plays a role in amplifying or attenuating risk. One of the key elements of let's see if I can move so when we talk about amplification, first thing is, if you look at the right hand side of my screen or the slide, you see that risk information can amplify the threat, so that can increase the level of threat, or it can attenuate. So when we say attenuate, it decreases the importance of that risk. So risk communication, as it flows at different levels, can either amplify the threat or attenuate the threat. When threat is amplified, there can be large levels of anxiety and people may take undue action. When it is attenuated, people may not take an action, thus exposing themselves to the virus. This model has been applied earlier also in relation to the BSE infection, or the SARS infection that had taken place earlier, or the bird flu infection, other terminology that I use. In some cases, some countries in Europe, for example, ordered large amounts of kits for testing these things. And they amplified the risk, saying that, oh, we need to have a lot of tests. But many of those tests were not used because the epidemic had not yet reached that proportion. So then there was an amplification of risk information, but that led to certain actions which kind of amplified the importance of that thing, but the action was not necessary enough for that. The same goes if you take the other way around of attenuation, is that how information when attenuated. So if you look at this graph over here, risk event moves through different levels. It can be at institutional level, so government, media, experts, epidemiologists, people speaking for the government regarding the spread of the virus. Social stations, that is cultural, social groups, families, cultural groups, religious groups, your working group, all these things of social stations which play a role. And then at the individual station is the individual. How does the individual react to it? At different level, risk information can pass through and get either amplified or attenuated. depends upon what is the nature. Each of these institution levels play a different role. So governments can attenuate the risk, uh, thus not investing enough on informing people. Social stations can amplify the risk, thus creating certain groups or discriminating certain groups and othering those groups have as being the kind of carriers of the virus. At the individual station, you can either both attenuate or amplify. If you amplify the risk, you have heightened level of anxiety. You may take drastic measures to control these things, which may not be in line with the recommendations. You can attenuate the risk, and that you see with many of the cases now with people walking around with masks under their nose. And then you feel like, yeah, so what is the point of the action? So when we look at people's actions, we should not judge them based on what they're doing, but look a bit further back. What kind of risk information have these groups received? Their actions depend a lot on the information processes that are there behind this thing. So the social experience of risk has to be understood through the flow of information across these different stations. So the framework, it tries to explain these information processes, institutional structures, the behavior of social groups with this information, and how do individuals react to it. With regard to institutions, we've already seen that with different epidemics, the people take different actions. And each of these epidemics require government machineries to very closely interact with epidemiologists and government Ministry of Information and Broadcasting, for example, on how they give out this information. There can be multiple sources. So when we work within a democratic framework, we have multiple institutions who may not be giving the same kind of information as well. And that already creates this amplification and attenuation, creating thus confusion at the social stations. When we come to the social stations, here, the believability of that information provided depends much on the trust and confidence a person has in the messenger. If the person does not trust the messenger, and messenger is not necessarily a person, could be an organization, could be the, the group in which the messages have been circulated, or it could be the healthcare provider. These social stations play a role in understanding how risk information is either attenuated, that people say, oh, it's not our problem, it's someone else's problem. I live in a high rise, it's not my problem, it's the problem of the slums. So that's a kind of an othering of risk where social stations can say, okay, that's their problem, so I'm not going to take any action. It can be amplified, and institutions or social stations or government machineries can cordon off areas. That's what we've seen within COVID-19 as well, that certain areas were cordoned off without much information of what happens if you're being cordoned off. What happens if you're being put on forced lockdown? How do you deal with this? How do you come out of it? Has this information being circulated? That leads to this additional anxiety among social groups. The second element, what's been disrupting much of the trust, is this concept of infodemics. So like epidemics and pandemics, we have infodemics. It's an overabundance of misinformation or information that makes it hard for people to find trustworthy sources and reliable guidance when they need it. When they don't have trustworthy sources or reliable guidance, they tend to um, cling on to information which is easily comprehensible to them. And this information may not be the best or the most right information in that context. This is what that they can easily understand, easily fit into their cultural framework. Social media, and that you may have seen across this whole lockdown experience, can heighten the spread of misinformation or infodemics, thus increasing anxiety and discrimination. Especially in groups with have one, they are non-experts. Second, they don't have the information how exactly is the spread taking place, or they do not know how do they need to react to this uncertainty. This leads to this level of anxiety, but also discrimination of particular groups, which at a social station can have both this amplifying and attenuating effect. So together with Isaac, we and other institutes, we have this Equimob project. We designed a survey to understand how older adults experience the COVID lockdown, what were the perceptions of safety. This data we are still cleaning and analyzing. So I'm just going to present a small snippet of the data that we have. So we asked, do older adults trust the sources of information? So here you can see that when you ask people that do you trust information, they say yes, of course, from the government and from the health practitioners, we trust this information. Whereas media, relatives, and friends are relatively less. Whereas social media suddenly becomes that we don't trust this information because of this infodemics that takes place. What we have to also realize is that in comparison with the government and the health practitioners, the ones within the social media are the people themselves who are participating in the spread of information. So it would be actually interesting to do research on to ask people how do they know which information to forward and which information not to forward, for example. And when there is uncertainty, when information is presented to you in a believable manner, you may pass on this misinformation thinking without thinking about the originality of it or whether checking or the authenticity of it. In some situations, you may not be able to check the authenticity of it because there is no reference mechanism to check this authenticity. So this can lead to heightened level of confusion, especially in these social stations. In the third level, so individual beliefs, heuristic decision making, and past experience have a direct bearing on risk perception and its ensuing behavior. At the individual station, if you have increase in risk perception, is a greater chance of that you would take an action. If you look at the health belief model, it says that higher the perceived threat is, the greater the chance of taking action. But at the individual station, even if you receive all this information, it's not that people just receive information and automatically act on them. They also have to make sense of this information. Some information maybe beyond their cultural framework, beyond the rationality in which they understand what's happening around them. When information arrives at the individual station, that information that is congruent or conversant with the cultural framework, the cultural meaning system in which people live, that information is easily absorbed. If it is outside this the culture meaning system, if it is new, that they can't make sense of it, then this information is hardly, even if it is the right kind of information, it's hardly taken into account because they don't have the skills to understand this information. They don't have the skills to process this information. The risk, let's take the same example of the two families within Isaac campus. If we say that before this condition, that there was maybe a sense of protection, saying that, oh, we are far away from the city and this doesn't happen. The minute it happens within the campus, then it changes the whole dynamic of risk. It changes the whole dynamic of risk perceptions as well, because there is a direct experience with someone. So having a neighbor or a known person infected with COVID or with any other illnesses, depending on what you're studying, increases the risk perceptions much higher than hearing about the news that it happened somewhere in the city. So if it can happen to someone else who is also like me, then I am also more at risk of it. So this is at the individual level. You use these kind of direct experiences which can play a role in increasing level of threat, increasing level of perceptions, and greater chance of taking an action. So preventive and protective behaviors are highly dependent on this amplification and attenuation of risk information. If it doesn't come down to that level, saying that, oh, we are well off, we clean everything, and um, it won't happen to us, we will just go in for 5 minutes and come back, and then it won't happen to us. These are heuristic decision making. This concept of normalizing risk has been applied extensively within risk behavior studies, where they say that, for example, when you ask people to go off, adopt healthy behaviors, go off smoking, for example, they would say, no, I smoke in open air, so that would not affect my lungs. So there is a kind of normalizing of risk. So we say that, no, I will go only on my scooter outside and come back, so I don't need to use a mask, or I don't interact with people, so I don't. So people at the individual level take this information and convert it to actions or information that they can easily manage in their day-to-day lives, because realistically, people cannot drastically change their lives because of this COVID infection or because of any other infection or risk information that's coming to them. They have to adapt it. They have to adapt their lifestyle and their daily routines based on these things. If they cannot adapt, then that there is also a risk that this information has not and has been attenuated, and or they do not have the framework or the guidelines on how to adapt to this information. I'm going to present next some research that we've done with SAR for the amplification of risk with vector-borne diseases. This is a project that we've been doing since 2014. We're following a cohort in Curacao. It's in the Caribbean islands. And here we focus on dengue, chikungunya, and Zika, which are also febrile illnesses, like fever-oriented illnesses, but are vector-borne diseases, all caused by a mosquito. We applied the same framework over there to understand three different diseases. So that could be on dengue, chikungunya, and Zika. We've recently published on the dengue and chikungunya part of it. What we saw over here is that the channels of information was quite important, is that there was a high reliance saying that, oh, we should put everything onto the internet and that will spread this information. What we realized while following this cohort is that as age increases, the dependence on internet for information also goes down. People with low socioeconomic status also found difficult to access information through the internet, and they relied on other sources of information. Trust in government and healthcare also took a beating, in a sense that in communities or societies, we've seen that those societies who have a contentious relationship with the government, who do not trust the government pre-epidemic stages in that sense, have greater difficulties in trusting the government and the healthcare systems during epidemics, because they are not sure that the healthcare provider is giving them the right kind of information or the information that is conducive to the well-being of the individual. So trust in government and healthcare, depending on where you're located in the socioeconomic status ladder, that played a role in people trusting information or not. What was also difficult, we see both in the quantitative and qualitative data that we collected, was this changing messages, constant changing of messages and confusion that these changing messages created. And also non-cooperation with the media. What we saw that the government was giving certain kind of information and the media was creating its own information. And because the media did not receive any or numbers or cases from the government, they were not ready to cooperate or give. So they started to cook up their own cases. That's how we have seen this case and we have seen that case, and that plays a role in this process. One of the key elements was that even though the government was aware of chikungunya and dengue in this situation because of previous epidemics, the late delivery of information. So timing is very crucial in relation to risk communication. When does it happen? So risk communication has to go through the whole process. So that is before, during, and after. So it just doesn't start at the height of the epidemic. If you start risk communication, that's too late. And as in this case, the late delivery of information, and that we saw is that even though they had very interesting booklets that they created for people, they did not have time or the human resources to deliver these booklets, and that created already a block in this risk information uh, pyramid or channel that was created. If you have questions, I would be happy to answer from this project as well. So coming to, sorry, there's a typo there. COVID-19 and risk communication challenges. One is this too much of information. What we see is that this kind of infodemic, that there's too much of information and people don't know which information to trust. Low literate and people living in precarious situations are ignored, in a sense that the risk communication does not take into account how do you make sense of physical distancing in a slum, in a chawl, for example, when people live very close together. How do you then talk about physical distancing? How do you talk about physical distancing with regard to working next to each other in cramped garment factories, for example? Um, so risk communication has to be contextualized to particular groups, and has to give them, in addition to avoid doing this, what else can you do? So it's not just that saying don't do this, but if you need to do this, what else, what mechanisms you need to take into account to be ready to conduct that act? Because you people have to continue their livelihoods, people have to continue their work. What are the steps people can take? The lockdown itself has been a very interesting case in terms of risk behavior studies, but also in terms of living with the condition. Actually, with earlier epidemics, we see that there was always this with dengue or chikungunya, for example. We saw that there was a start of the epidemic, there was a peak, and then it went off, usually pre-monsoons or post-monsoons, and then there was a lull period and there were no infections. But with the lockdown, we saw that it came on suddenly. There was no preparedness, has had a greater impact on the particular groups, especially people were not aware of what does it mean to be a lockdown. In many situations, let's take the example of India. We're used to bandhs, for example, or strikes. But there are some parts that were still open and you could go out. But this lockdown changed the whole dynamics of it. So as social science researchers, for us, it's also important to understand what does this lockdown actually mean, and for whom is this lockdown, and which groups actually benefit from this lockdown, and which groups are negatively impacted due to this, and is it really feasible in countries with uh, high levels of informal workers that you can impose such a lockdown? What about their livelihoods, for example? So in that way, there needs to be much more um, unpacking of the concept, critical engagement of what it means. How do we prepare for the next pandemic if lockdown is one of the key measures that we have to use? The other part, and this has been highlighted a lot recently, is the mental health impact of the lockdown, of COVID-19, of people being stuck at home, abuse and loneliness, for example, for older adults, women, people in um, abusive relationships, children, for example, living at home, the homes not being conducive for this kind of constant 24/7 living within these paths, how that hasn't had an impact and how that continues to have an impact on those particular groups. How do people come out of this? So I think as social science researchers, we have a big role to play there in understanding what has been the social impact of this lockdown, both from the understanding of physical distancing, but also in terms of what has been the mental health impact, both at the individual level, but also at the family level. Again, I would like to stress that targeting of information and contextualizing is important, especially for different groups, different low literate groups, physically disabled groups, people who cannot read, uh, visually challenged groups. How do you pass on this information? How do we set up different channels of information to reach these different groups? What we propose, of course, in continuing with this is we need a kind of an implementation framework that should provide an audit style checklist to recognize what are the barriers and bottlenecks in risk communications at these various levels. So at the institutional level, the social group, and the individual level. We need clear guidelines on timing, design, and framing of these COVID-19 messages to various audiences. Uh, Plus, we need clear communication strategies for future outbreaks and for other epidemics. I think we have a huge learning curve to make over here in terms of understanding the timing, the design, and the framing, and how that has changed over a period of time. We can't use the same kind of material over the whole, the before, during, and after kind of phase of it. So risk communication has to encompass all these three elements and to have different designs. I should say, there have been quite some efforts by different organizations in dealing with this information. What I know in the Dutch case is that for refugees, we have a large portion of refugees, not large, I mean, for an Dutch population, it's large, of Syrian or refugees who have come after the Syrian conflict. So the organizations, the local health authorities started to translate risk communication or these pamphlets into Arabic, for example, or into other languages. They translated it into 16 different languages so that it can reach these different groups, because many of these vulnerable groups live in very precarious situations. So they have, even if they get the national update, which is in Dutch, they may not be able to do much with this information, or they may not know, okay, yeah, this information is there, so what do I do in my daily life? So that's this design and framing component that we need to take into account, both for protecting people, but also um, the step forwards, what people can take once they have been infected, once they have come out of the infection. What steps do they need to take, and how do they can protect themselves and people around them? So that was most of my presentation. We will publish more from our Equimob projects, from the surveys that we did on the COVID thing on the site. If you have questions, please email us, follow our regular updates on our social media. I once again thank Isaac for giving me this opportunity to talk about this topic, and I'm open for questions. Thank you.
Thank you very much, Mr. Rajay Bailey. Of course, it's a it's a it's a wonderful lecture emphasizing the social implication of the risk framework and the COVID-19 risk communication challenges and need for a comprehensive framework. So you put it in a very nutshell, and of course, it's all quite useful. What's happening in Isaac? That's what the example which I said you have taken up. So there is behavior changes. So it's a really highly educative and very thought-provoking and very interesting lecture. Sobin, are you all right? Would you like to moderate?
Uh, am I audible? How is it now?
Now you're audible. Please moderate.
Okay, thank you very much. I joined Professor Madheshwaran in thanking Dr. Bailey. It was really an engaging presentation, and he in fact opened up a lot of challenges with regard to risk communication in the context of our social and economic complexities that we have. I'm sure that there will be a lot of questions. We have two options. One is that you can post your questions on the chat box, or you can raise your hands. If you see the emojis of the hand there, you please click on that, and I'll identify, I'll spot you from that, and then I'll open the session for you. Who would like to come first?
Well, well, it's not a question, it's a comment. I'm Rajashekharan Nair. I'm heading a public health institute in Trivandrum, known as Global Institute of Public Health. It's an excellent presentation. I like that you covered a large canvas. But what I would like to present before you is the context in which this risk communication takes place. For instance, in India, the age-old 18th century, 1897 Epidemic Act was invoked, and that led to a lot of oppression among the people. Like the police was used, even in a progressive state like Kerala. The police are being used to control the people. I mean, so it is in that context we have to see this communication. And for instance, I mean, one of the major issues that we are working on is the whole notion of fear in communication. Fear was involved, and it was successful in some other instances like tobacco and smoking, anti-smoking campaigns. The fear was involved, and it was slightly successful. I mean, I would say Kerala, the smoking came down sharply because all the films start with this message. I mean, in India. And they show very depressing kind of visuals. But in this COVID case, and we find that people were threatened to some extent, and the whole Epidemic Act led to some kind of fear, and the fear of death, not just fear of the infection, fear of death also played an important role. And you rightly mentioned about the role of infodemic, which we worked extensively. I have also published on the mental health consequences of COVID in international journals. Maybe you can go through them. But this is an important issue that we have to take care when we communicate something to the people. And you also mentioned about uncertainty, which also I enjoyed listening to that. Especially when WHO was so unsure about the whole scientificity of the COVID symptoms itself. They kept on changing the symptoms, and even day before yesterday, they issued a new guideline, and every week they are changing the whole notions about the disease. So that is what I want to mention. And another thing is that the whole control mechanisms, it was nothing new. There was no innovation in control mechanisms like use of masks or use of the physical distancing, etc. But because they were very age-old practices, like John Hagart's well-known principles, which was there during smallpox epidemic in 18th century. So they used that. There was no new innovation or nothing which was transmitted to the people. So these are some of the issues that we have to highlight when we talk about risk communication. Thank you very much.
Thank you very much, Professor Nair, for this interesting intervention. I can see a queue forming now here. Professor Pramod Kumar, please ask your question. Kindly unmute and ask your question. Professor Pramod Kumar, please unmute. We can't hear you.
Yeah, sorry. Thank you, Professor Ajay. Very comprehensive lecture. You have talked about social aspects of pandemic. I have one or two points to raise. The first point is you have worked thoroughly in this area. Do you think India overreacted by imposing lockdown at very early and for quite a long period? And then ultimately, when pandemic came at a large, we don't have the space to go back to the lockdown. And now we have 60,000 plus cases coming every day. But we are, rather than the lockdown when there was hardly 100 cases, less than 100, we had a prolonged lockdown. And now we have such a huge numbers, but we don't have the space to bring in lockdown. Rather, we are opening up other activities. Now our schools are also going to open when we are approaching almost 1 lakh cases every day. So do you think the lockdown, was it a right strategy to have a lockdown, or in such a pandemic, which is a long period prospective of disease, which is not going to be controlled very immediately? So lockdown is irrelevant in such a situation. Also, you said targeting. So when the government distributed all kind of, we imposed the lockdown, and we ultimately found that we were not prepared for the same. And when there is a question of the basic amenities, food, then somewhere state governments in haywire, they started distributing food. There was no preparedness. So in such a pandemic situation, what kind of targeting a country can adopt? If you can highlight these 2 points. Thank you very much. Thank you.
Thank you, Professor Pramod Kumar. Ajay, can we take 2 more questions, and we will answer these, then we'll take another set of questions, right?
Sobin,
I can see Veeresh is raising.
no, Sobin, please let me complete. See, there are some 3 hands raised. One is Professor Lakshmana, second is Kalasridhar, third is Minachi Rajiv. I don't know whether you have seen their hand. And then 2 questions. One is our student Viresha and Ramakrishna Nair. Yeah, this first you read this 2 question, and the 2 question asked. This is one set of questions Professor Rajai can answer it. And second set of question is from Lakshmana and from Professor Kala and from Minachi and others. So that's the second set of question. You can make it like that. Yeah.
All right. Thank you for that. I think then let Professor Lakshmana can you please ask the questions. So we'll take these 3 questions. Then I'll read out the questions which appeared in the chat box. Professor Lakshmana, please.
No, unmute. Unmute. Lakshmana, unmute.
Okay, now, sir.
Yeah.
Okay. So thank you, Dr. Sobin, for giving me an opportunity. Hello, sir. Ajay Beli. Hello, sir. How are you?
I'm fine.
Anyway, thank you for your thought-provoking lecture on this pandemic issues. Just I have a question I want to clarify by you, because when the COVID was started in March, I think there was a connection between density and the reported cases. So that same thing I would like to ask. I have done something to give some media. There is a perfect correlation between density of population and the reported cases. For example, if you look at India, go to Goa, Maharashtra, and Gujarat, 60 to 70% of cases were reported. So other state, for example, South India and Eastern India, there were no issues. It is like the Western region, because Western region is already reached to the urban population is reached to the at least Western style. That way, I need to understand whether any connection between density and these reported cases after long period, after 4 months. This is what I want to know from you. Thank you.
Thank you, Professor Lakshmana. Now, Professor Meenakshi Rajiv.
I have 2 small questions. One is that the previous speaker has said that all these remedies or all these precautions we used, like mask, like distancing, these are already there, these are already known. But then when we have such an international disease, we look at WHO for prescription. But there also, even though these are earlier prescribed, for example, mask. Earlier they said mask should be worn only by person with symptoms and no other person should be use mask. Now they are saying everybody should use mask. So even those things are, their prescriptions are changing. That is number one. And number two, I feel that media reporting, we also look at media's report about these cases, but when we look at media's reporting, sometimes it is so intimidating that there are many cases where cured people have committed suicide because of the fear of that, the fear that it creates to the neighborhood. People are not allowed to go back to their home and all this. So is it what one should do in such cases when there is over reporting of the fear? Thank you.
Professor Kala, please.
Unmute, please.
Yeah, thank you, Dr. Sobin, and also Professor Madheshwaran. Professor Bailey, it was indeed a very, very fascinating and thought-provoking lecture. And I'm not an expert in this area, but I'm sure that not much work has been done on risk communication during a pandemic like this. I really enjoyed the lecture. Having said that, I think it was very interesting to see one of your graphs where people thought any communication from the government on this is very, very credible, right? So one thing which I noticed across the globe when this was going on, the lockdown was going on, is that in the US and European countries, I think there's a lot of shortage of toilet paper, right? Because of this irrational expectation saying that, I mean, all these things are going to be removed off of the shelves, right? And in India, during the lockdown from March until May or so, there was a severe shortage of some grocery items, right? Regular grocery items like coffee, tea, rice, and I myself experienced some of those things. So I wanted to know if in the context of the Netherlands, whether because of a certain like risk communication through social media like WhatsApp or something, was there a severe shortage of something, or was there a risk really that came to the people because of this during the lockdown there in the Netherlands? Thank you. Thank you very much.
Thank you, Professor Kala. Ajay, would you like to respond now? Then we'll take another set of questions.
Yes. So I'll start. Thanks a lot for the questions. Very interesting. I'll start with Professor Nayar's comments. Actually, I found your comments very interesting. I would like to pick on this element of fear, actually. And if you look at most of these health communication campaigns, a lot of that is based on this fear of in. And why do these campaigns rely on fear is to increase this threat perception. So if you look at, you also use this example of smoking, including in Europe, they do this. They include pictures of lung cancer onto cigarette packs, for example, to increase this sense of threat that people would feel. Or this fear mechanism is supposed to be understood within social psychology as a way to push people to take an action. Yeah. So this fear can be instigated through these pictures, through these visual cues, or it can be made to. But fear as the only medium of communication does not help in pandemics, because one has to go beyond that fear. I mean, I can be feared for living under fear for the first few weeks of that lockdown. But after that, I said, yeah, it's not going to work. I'm just going to go out. Yeah. Would that work? Would that change things? I think that's something we have to critically engage with health communication scholars or even campaigns, is that how do we go beyond this fear inducing thing? How do we make it that, okay, you may have had it, or if you have it, then what do you need to do? And That's the thing. So it goes beyond fear, and it kind of also normalizes it to say that, okay, you could have it, plus you need to take these actions to go further. Because ultimately, you want people to change behaviors. You want people to adopt new behaviors. So, but fear, relying only on fear without showing the perceived benefit of taking an action will not, in those cases, behavior change is not sustainable. But I would be happy to discuss further on your work regarding fear, especially in the Kerala context. I come to the next question by Professor Pramod Kumar on targeting. Targeting is a very, if you look at it from when I speak, on one side we say targeting, and on the other side we say contextualizing. So maybe it sounds as an oxymoron in that sense, but it's not. It's actually finding ways by which we can reach out to these groups that are hard to reach with specific information, because the information doesn't change. It's just the channel by which we reach to these groups will change. The language may change. This example I gave of how Dutch organizations are reaching out to refugees or to undocumented migrants is by translating this information into a language that they can understand. Of course, in that particular group, maybe there are some people who are who cannot read, for example. What about literacy levels? In those cases, what these organizations also did, they started to have a helpline or to send SMSs from these organizations, or they can have an open line to call up to set up testing for COVID, for example. So that kind of contextualizing, that kind of reaching out information is what we should aim with this, with the targeting I meant. You asked me also a question of whether we were too early in the lockdown or was India too early in the lockdown. I don't think so, because I think even in the Dutch case, they started off the lockdown. In some scholars over here say that it was too late. Some say it's too early. It's just that there was no previous experience with lockdowns, especially in relation to these kind of illnesses. So then it became even more difficult to understand what is the timing that it should be imposed. Lockdown is a very serious, as you and me have experienced, a serious cut from our social fabric, actually, that we have these social relations that we can't maintain anymore, or economic or work related stuff. So I think going forward, there needs to be a more critical evaluation of the lockdown itself. And if we have to impose it again, be it at a national level or at a regional level, then what steps people need to take, that it doesn't create fear or anxiety in particular groups.
My question is, would it have worked better if we could have 3-4 stretches rather than having one long stretch and then there is nothing?
Yeah, it's difficult to answer because of the level of or the extent of mobility that takes place in India between these regions as well. I mean, if these are regions which can be easily closed down without mobility between those places, then maybe you could try to isolate these things. In the Dutch context, southern Netherlands, for example, experienced it first, whereas northern Netherlands did not, Groningen, for example, did not experience it for a very long time. So for there, the sense of risk or the sense of actions to be taken was much lower. So now with the second wave that is coming up in the Netherlands, they are thinking of regional lockdowns and not national lockdowns. But lockdowns also have to, have the political willpower. I know in Karnataka they started it, but then they stopped in between. So that also plays a role in this process. I come to Professor Meenakshi's question. Mask, no mask is a hot topic actually here in Netherlands as well. Netherlands says no masks. Schools were opened before the summer break. So my son went to school for 3 weeks. Our neighboring country, Belgium, imposed masks in all places that you have to use. So even within Europe, within European framework where so much of information is available, so much of it is coordinated, there's quite some discrepancy between what individual governments provide. So if you remember my slide, which I talked about amplification and attenuation, at institutional level already this thing happens, and there we have to, when institutions say yes you can do this or yes you can't do that, it's also the individual who has to take into account. If I go to my local grocery store over here with a mask, people will look at me a bit strangely because they think I'm infected with it. So it's this whole plethora of effect, because also people around me or communities in which we live, they are also not sure how to deal with this situation. So for them, this is a very uncertain time. So judging or evaluating if the person in front of me is at risk or is a risk for me is a constant evaluation people need to have in that sense. Yeah. Coming to Dr. Professor Kala's comment, in Netherlands, we went since March full-time into lockdown, but we have a lot of support infrastructures. For example, we hardly went out to buy groceries. We had a shortage, yes, of certain elements, but they already informed us in advance. Supermarkets sent out SMSs and news items saying when you can order what and these kind of things. But this, I'm talking from a privileged position that I can sit at home and order things on my mobile for these things. For people who do not have that luxury, for them it was more difficult to experience lockdown. Yeah. I'll take more questions if you have.
Thank you, Ajay. I have noted down 4 questions which appear in the chat box. First is by Viresha Nayak. He's asking how we can ensure legitimacy of disease-related information in the context of COVID-19, because we have so many information coming in, and how can we actually integrate in the framework? And a second question is one by Dr. Radhakrishna. He is actually asking about positive communication. What he views is that there are a lot of communication which are coming in the media and in the public sphere is mostly negative. It's about risk. What is the effect of positive communication, like the progress of the vaccine or the progress of the medicine that are being developed? How would actually change the entire scenario of risk communication? Third question is from Ms. Sudhamani. She's asking about the mental health issues that are faced by youngsters, especially who used to have a very rich social life and rich culture of mingling with others. All of a sudden, they are locked in a room and probably working, and how such situation would in fact lead to their mental health issues. And fourth questions, which I have noted, is one from Ms. Kirti. He is asking how fear is going to be addressed in risk communication. She is putting an example of people who are in fact reluctant to go to the quarantine center because of the fear factor. They also hide their disease information. How the element of fear can be effectively included in the risk framework so that it can be communicated with its possibilities and limitations. These are the 4 questions which I have collected from the chat box. Kindly address this. Thank you.
Yeah. Professor Ajay, that the previous set of questions you missed out some density.
Oh, sorry, Professor Lakshman, I forgot to deal with your question. With the density question, it's very interesting because with regard to epidemics, you may know also as a GIS expert or geography expert, we deal a lot with hotspots, right? So hotspots and how that hotspot spread this information. What I found interesting as the COVID-19 epidemic developed is that suddenly there was this large focus on Maharashtra in India, for example, as being this hotspot, and that still continues to increase. But how slowly other elements started to pick up due to travel, due to moving of people inside. Density in any case with epidemics, especially in relation to these kind of epidemics where close contact plays a role, things can spread quite fast, but it also depends a lot on the immunity levels at those places. What we have seen with COVID-19 is different groups of people react differently for this condition. Especially here in the Dutch, what we have seen is asymptomatic transfer of the virus. Much higher. Sorry.
Kindly mute your microphones. Miss Dr. Lavanya, kindly mute your microphone. Thank you.
So density, yes, plays definitely a role. And as I said in my presentation, especially when people living in precarious living situations, who already have a lower health status and have difficulties in accessing healthcare, for them it's even more difficult in that sense. And then their density definitely plays a role. Yeah.
Thank you. Thank you very much, sir.
I'll take now the questions from legitimacy of information. And that's, I think, what Professor Madheshwaran also said, is that with the WHO, or Professor Nair said, is that the information is constantly changing as well, in a sense that as the epidemic develops, then there is new information coming in. And it is interesting, but also bit alarming that different countries react differently to the WHO information as well, in a sense that there is no comparative frame that we can look at, in the sense that if you saw with, I think over a period of time, this legitimacy would be developed based on WHO's reaction, based on how WHO also arrived at that information. Because we've also seen through this pandemic, this whole legitimacy issue of medical journals who reported on these conditions and how they had to retract papers, for example. So that kind of also questions this legitimacy. And that's where WHO, with certain medicines, they initially stopped the trial and then restarted the trial. So that is an example of where legitimacy is also an ongoing process. Yeah. Then you talked about positive elements, and that's something I dealt with earlier when I spoke about fear, is that we have to go beyond, health communication has to go beyond this fear creation. Fear is an essential element because it instigates people to take action. But in addition to that, one has to also show more positive elements to show what can you do once you have been infected, or what you can do for others, or how do you treat others with this. And a good example is this communication around HIV/AIDS. If you look at it in the beginning, a lot of communication on HIV/AIDS was on this fear-oriented thing. When you look at it, more recent things, once after the ART started everything, there was more positive. So they showed more that HIV can be with anybody and everybody. So everyone in the neighborhood. So it was not about those particular groups, for example. So those positive elements of communication, of representation of the illness, representation of the diseases, plays a big role. In some countries, we've seen that celebrities have come out to say, okay, I've had this illness and I've recovered from it. That plays a big role as well. Of course, those people have more resources to get better care. But that fact that someone can recover from something and can lead a life in this thing. So those kind of positive messages need to also come back into the media. We had this question on mental health. I think mental health is, I agree, it's not just about older people, but it's of everyone in the family. It's about the whole impact it has on the group of people, and how social stopping of social relations, or even moving a lot of this interactions online, how has that changed social dynamics? How has that changed social interactions? A lot of our communication, a lot of validation that young people get is through peer networks, actually. Um, that can be both in person, but could also that because they were already um, kind of adopted a digital way of through Instagram and other kind of modes of communication, maybe that did not affect them to a large extent, in that sense that a lot of some things that they were doing before, they could still continue afterwards. But I would agree, people, especially younger groups um, who are stuck at home, who have not been able to express themselves in these kind of situations, there would be mental health issues. Yes. Committing suicide is something that is very tragic, especially we've seen a lot of those cases. Um, I think Professor Meenakshi also highlighted this, where we saw this issue of, am I still audible? Ah, okay.
Yeah, we can hear you.
Okay, great. So committing suicide is also an extreme reaction to this uncertainty, to this information that has taken place, the misinformation that has passed, or could have been a result of discrimination. Hence, there is that need so that we can get out more information on more the positive elements, on actually not just creating fear, but also creating actions that people can take. The last question was on fear of going to quarantine centers. And this is an example of this behavior or an action by the government. Going to quarantine centers is I think Professor Nair would also agree, is an essential part of the age-old pandemic approach to it, that you create a quarantine center, you keep people there, avoid people mingling with the other groups of people. But it's not there in the general public mindset of what a quarantine center is. People thought maybe it's a prison, maybe it's that they would not get away from it, or they would be stuck within these places, or they may get sick in the quarantine centers. So when people are uncertain what these quarantine centers are, that plays a big role in people adhering to those things, or we've even seen cases of people running away from quarantine centers because of this fear that is created. So a part of risk communication has to also focus on these quarantine centers to show people what it is and why is it necessary to do it. Yeah, just telling someone, it's classic behavior change communication, wherein if you just tell people, no, you should do this, they will say, why should I do that? Rather, if you explain to people what are the benefits of doing that, there are more likely chances that people may participate in this quarantining activity. I think.
We have one last question from Dr. Talla Narayan Gowda. The person is asking, what are the effective health risk communication strategies during pandemic? This is the only question I can see here in the chat box. Anyone else has questions, they can raise their hands. Otherwise, we will go ahead with this last question. Is there anyone? Yeah, Jay, please go ahead.
Okay. Effective health communication strategies, I think, has to have a more, I would not just focus on communication strategies, I would rather focus on this framework that, for example, in environment sciences, you would have these whole disaster risk reduction strategies that you would have. You would have a whole framework, especially with regard to earthquakes or these kind of things. I think in the public health domain also, we need to come up with an implementation framework that lays the ground to say, what are the different possibilities? And there is no one strategy that will work everywhere. We should provide a toolkit of strategies that each government or groups can pick up and use depending on the context in which it needs to be applied. So this kind of audit style approach to look at barriers, to look at also enabling environments where risk communication can take place. That's something that we can always already include into it. and that it has to happen at all of those three levels. It's just not that we say, oh, the government is not doing it, but it has to happen across all these three levels, and how we can arrive at these strategies. Because at the end of the day, we need to empower that municipality person over there and tell that person, okay, in time of an epidemic, what is the framework? What is my guideline? How do I proceed? So it has to be up to the ward level. We should have information on how to proceed given a pandemic and what action people need to take. It's this uncertainty and lack of information that creates people to do things that are sometimes contradictory to the prevention of the epidemic.
Thank you very much, Professor Ajay. Before we conclude and give the floor to Professor Madheshwar, I would like to wind up what we have so far discussed. In fact, as Professor Madheshwar in his initial remarks noted, we still don't know what is this disease. In fact, we have a lot of uncertainties, even from the expert. The experts, their opinions are being changed every day. We have seen how kind of different kind of literature even appeared in internationally reputed medical journals were withdrawn. So we have seen such things. So we have a communication asymmetry, risk communication asymmetry, and improperness from the very top where the experts, so-called experts, are sitting, and to the level where we are consuming the information. So we have a huge problem of information asymmetry here. And second, in a country, vast country like India, we have, I think, more of an evolving situation. Most of the time, the authorities, the people who are at the front line of COVID preparedness and prevention, they will have to go by their own calls. They have to take decision instinctively. And in this case, in this sense, how we can, in fact, make our such risk communication framework more dynamic? How can we also include the element of feedback, which is actually getting day to day? Because these things are changing across context. We have seen such situations are changing across context. And when there is a situation when somebody is reluctant to go to a COVID center,
I can't hear you.
Is that Sobin over?
I think Sobin got disconnected. Yeah.
Disconnected because of his weak. I mean, bandwidth is not very strong. It's a weak one. Ajay, of course, it's a wonderful lecture, and you have really flagged all the issues. Basically, the social amplification of the risk framework. Basically, that we learned that the social application of the risk framework, that's very important in this context, and also that what are the risk challenges, what are the risk communication challenges that basically it's needed, and also what we need a comprehensive framework, because as I said before, is that the risk communication has been one of the weakest link in this pandemic intervention, especially in the poor regions of the world. So really, your information will be quite useful. And yes, Sobin, I'm going ahead. Don't worry. Yeah, he's giving some message to me here. Really, this particular lecture has raised quite a lot of issues, and the lot of interesting discussion went off from the ISAC fraternity students and the alumni and the other participants. And thank you very much for giving your concern amidst of your, though it's a lockdown, most of the academicians in the Western world, even in your third world, are busy in completing many projects and writing papers and so on and so forth amidst of and online teaching sometime. And yeah, I know online teaching is very important than completing projects, and which is a very difficult one than completing projects and writing papers. So amidst of all these things, we had given a concern, and on behalf of ISAC fraternity, once again, I thank you for sparing some time with us. And also, we need your continued collaboration. Of course, you have been collaborating with us with the ISAC fraternity, and we need your continuous collaboration, which should go for a long way.
Definitely.
So thank you very much, sir.
Thank you. Thanks everyone for your comments. Thank you. Bye.
So
Thank you, Ajay.
Bye.